Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you are new to us, welcome. We are super excited to have you here because for a few different reasons. We're having some incredible conversations with real leaders that are painstakingly reshaping the future of healthcare. So, our objective is to bring these stories to you and bring them to life. So, if it's your first time tuning in, let me just sort of take a quick step aside and just sort of fill you in a little bit more about what we're really trying to get done here. So, again, our focus is to bring real stories of innovation and leadership and transformation and access to life, and not just stuff that you read in an article, but like real stuff, people that are in the trenches getting things done. And the objective is to just to kind of shine the light on those that the light doesn't necessarily get shined on. Because when you think about innovation and all these things, 99% of innovation happens outside of the organizations that we've all come to know that are innovators. So this is going to be a really fun conversation. If you haven't checked out any of our historical interviews, wherever you are now, if you're watching this, if you're listening to this, however you're consuming this, please hit the subscribe button now so that any of the new interviews come directly to you. So I'm super excited about today's conversation, but I want to tell you a story. And it starts in Taiwan. A woman leaves. She comes to America. She doesn't know the language. She doesn't know the system, completely in a new environment. She takes her citizenship tests, passes. She takes her driver test, passes. And then she starts a company in 1992. This is one of the first female-owned IT companies in this country. Um, she then passes it to her daughter. Her daughter passes it to her granddaughter. Three generations of women, three generations that are building something that lasts. And if you all have been listening to the show for a while, you know that I have this fascination of duration, enduring, building things that last. And sitting across me right now is the granddaughter. Sunny Lou Williams is the president of TechServe Corporation. She's a Purdue alumni, Kelley School MBA. She's the winner of the 2024 Burton D. Morgan Entrepreneurship Award. Sick resume, background, amazing. And here's why I want you to pay attention today, because there is $50 billion on the table right now, federal money sitting inside the Rural Health Transformation Program, built to do one thing: transform rural healthcare inside of communities that need it most. So Indiana alone, I think they got like $207 million, according to my research, just for 1 year. Like, so the clock is running. And the question is, whether rural providers and communities who need this most actually can do something with it. So today's guest, Sunny, is going to talk about that. She and her team are launching this Rural Health Transformation Program advisory services in partnership with the Indiana Rural Health Association. So we're going to talk about a bunch of things. But you know what? I think she's figured out something that most people in this space haven't yet. So, Sunny, it's great to see you. Welcome to the show.
Thank you so much, Michael. Phenomenal. I am already just excited about not only where the country is going, but where each and every single rural locality has the opportunity to position themselves. But they have to show voice, and they should have to
Mhm.
show really endurance of participation where they're leading. And I
Mhm.
love the context of how you framed this, because it goes back to being very relational in order for us to be communal to get this work done together.
Totally. So before we dig into all that, because I'm the son of immigrant parents,
Yeah.
and your grandmother came to this country and not speaking a lick of the language. She started a company, um, and I kind of want to start there because I think that story to me tells us everything about who you are and why you're doing what you're doing. So sort of take me back. Um, what do you know about like why she did it?
Yeah, tremendous legacy, right? Big shoulders too. Have to continue carrying forward. Well, so my grandmother and my grandfather had some just tremendous opportunities over their lifetimes, just just huge changes within the world. And because of that came tremendous opportunity. So my grandmother had always had this entrepreneurship um, area of focus where she just looked around her and said, how can what I do make my family's life better? And how can it connect to what my children are doing at the time?
Mm,
Before she even came to the States, as her children were growing, she had a number of just kind of small neighborhood businesses, a coffee shop, an ice cream parlor when the kids were
yeah.
at middle school that really kind of exploded as they went into high school, and just leveraging the local workforce, training her kids' friends, and just having everybody be inclusive and as part of the business.
Right.
Well, during that time frame, the US put out a policy inviting talent to the United States under what was overseas known as a computer science visa.
Hmm.
Like if
Hmm.
you were in that field, then you had an opportunity to come and literally establish the American dream. And so, of her four children, three of them went on the computer science visa and came to the United States. And she said, you know, if they're going, that's the path. So I'm going to get ready and get excited. And so she started learning English through, I almost said podcast, but radio stations back in the time that had English language learning for little kids. And she, no embarrassment, no holds barred. She said, that's what I'm going to do. So
Yeah.
she had a passable conversational English, but she's 94 now and she still listens to now podcasts, and she's got her own on her cell phone, her list of things that she
Yeah.
listens to in English to not only keep up with world politics, but just
Hmm.
industry, right? So she came to the States, and that was her new learning challenge: how to communicate,
Yeah.
look at the environment, see the neighborhood in a totally different way. And
Yeah.
so my hat's off to her. She's just a force.
Yeah.
And
I was going to
has
say an example of a growth mindset living it out.
absolutely 100%. And when you think about it, that transforms everything, right? When you as an individual has a growth mindset, when you have the opportunity to say, in this current pain point, I'm not going to see this as a negative. I'm not going to see this as a challenge. I'm going to see this as, how can I do better? And what is the opportunity? And then to transcend that to, what is the system that is
Mm,
holding back? And how
yeah.
can we transform the system? That is what we're really seeking, not only in individuals, but organizations writ large, to ensure that we are improving as a society overall.
Yeah. Since kind of going in and digging in and just sort of, prepping, researching for this conversation, I've been sort of pondering, your third generation to lead this company. Like that's like kind of a heavy weight that falls on your shoulders that I don't think many either understand or even fully appreciate. Was there like ever a moment where you thought, that this isn't my path. I'm going to do something entirely different.
I had that very early on. So, interestingly and ironically enough, I apprenticed under another family business for 15 years before
Okay.
I came and took on the helm of our family business. And it was a very humbling experience across the board, right?
Yeah.
I had the pleasure, in hindsight, of graduating, and I say pleasure kind of tongue in cheek, during every major recession. And so there wasn't a lot of opportunity. So you had to have some fortitude to say, okay, you're just gonna land where you land and do and learn what you can, and then structure the path. So back in 2004, coming out of undergrad, I started part-time with a telecom firm, and I
Okay.
saw the difficulties of running and continuing to scale a family business when personalities clashed, when you still had to be parent and child, right, and
Yeah.
sibling outside of the work environment, and how much strain it took to really have a functioning business, let alone a very supportive family. And
Right.
so it took things bigger than the individuals themselves
Hmm.
really want to strive towards that. And so I took those lessons, some were what not to do, into our own family practice and really ensured that as I came on, we had a 2-year transition period, that I
Hmm.
was very clear to the leadership that were family members and the leadership that were not, that
Hmm.
this is the culture and this is how we are going to treat each other, and this is
Yeah.
how we are going to have communication and understanding, and of course disagreement, but all
Was
within.
that a new standard that you were setting, or was it sort of kind of in kind of lockstep with what the team was already used to?
I will say that it's a little in deference to, and of course, out of respect to my parents and my elders, I would say that was a newer standard. I think
Okay.
culturally as well, when you have organizations that are made up of individuals that are very strong in the immigrant culture and then also very strong in the East Asian culture, you have a lot of deference. And
Hmm.
so when you have deference, you don't necessarily have all the best ideas come to light. And so we really had to
Mm.
work on accounting for, I want to hear what you think, but I want you to back it up with research. I want you to have a solution. I want you to really be positioned to say, this is why we need to go in this direction, rather than what was happening, which was more of a risk mitigation led
Yeah.
conversation,
Yeah.
and
Yeah.
more of a, this is not how we used to do things, but
Yeah.
less on a tactical, more on a strategic level.
Speaking of, new direction, in 2018, you made a pretty bold move. You acquired a healthcare division, a population health management platform,
Yeah.
and you started to steer the company in a new direction. Walk walk me through that. Like, what did you see?
So great question. When we first started as TechServe, it was very core hardware, computing, asset management, and
Yeah.
full on installation projects. By the time you went to 2018, that was not the course of business and really not the areas of specialty. So what I thought was interesting is what a tremendous book of business on the private, or excuse me, on the public education side, as running it as a private
Yeah.
sector company. And the aha to me was, we have families going into the school system on a daily basis that are not receiving population health,
Yeah.
right? They're not receiving mental health, behavioral health, primary care, any of those components. So this is a front door that we have totally missed. It's not barred. It's fully resourced and run.
Hmm.
And there's even occupancy opportunities of having healthcare be specifically supported within these environments. And
Yeah.
so we looked at the population health, really as an opportunity to go, you've got family nights. Everybody understands what a health fair is, right?
Hmm.
Extend that access, extend that service. So we
Yeah.
literally went from hosting health fairs combined with back to school nights, family engagements, and parent teacher conferences, through to having then the providers come in, sequence, schedule, and stack their services in support of helping the school communities and thereby all the families
Yeah.
within the neighborhood. Because if you look at it, you have choices in your commute. You choose where you work, where
Yeah.
you work out, where you go to church. And a lot of times the length of commute is longer. So you're bypassing your own neighborhood.
Yeah.
But the commute where your kids go to school in a public environment, so public
Yeah.
school,
Hmm.
is still limited by where you live, right? Like charters,
Yeah.
vouchers, all of that is creating a whole nother a whole nother challenge to that. But for the most part, public schools, you are bound by where you live. So that commute really defines neighborhoods.
Yeah.
And when we look at that, and the aha was, of course, we would do population health on a neighborhood level. Why would I wait to go through and resequence all of this data from managed Medicaid or resequence the data from the hospitals? Who knows what that front door was? Maybe it was
Yeah.
the closest ER and they're in a rural environment, it's 40 miles away. Or maybe they've gone through 7 different ERs, different health systems
Yeah.
within the last couple months. So the school environment became our stamp in the ground of this is where localized healthcare access should be fortified in
Yes.
order for our neighborhoods to be healthier. And so we went through all sorts of partnerships, FQHCs, federally qualified health centers,
Hmm.
that ended up doing HRSA designations as satellite sites inside of the school.
Hmm.
And also partnerships across providers that say, hey, I don't have resources to staff every day. I go, great. It's a program then, right? What hours can you do?
Yeah.
What does that look
Right.
like?
Right.
And then students, families, teachers, staff, how can we get connected to ensure that we've got your appointments set for those that are in the greatest need?
That's amazing. Talk to me about StatWatch and like what it actually does in the real world. Like, what does it look like on the ground when it's working?
It's interesting. It is 4 things in one.
Mm.
So the first one is it's a comprehensive health fare management
Yeah.
system. So check in, take all your vitals, go do your labs, etc. Then you get the access to your print out because health fairs are still very physical, very
Yeah.
paper form. But you get it in basically tied into email, and because we are the provider and we share business associate agreement with all the covered entities, now you've
Yeah.
got essentially a very, very light community health information exchange from that health fair,
That's
right?
right.
And so that's iteration one. Iteration two is it's a case management tool. It's a very simple case management tool
Yeah.
for front end entry level healthcare workforce and also very veteran workforce that do not have access to tools because my goodness, we're still not spending dollars in support of those that go into the 4 walls of the home, which doesn't make
Yeah.
sense to me, right?
Yeah.
So the system has been used by community health workers, peer support professionals, uh, doulas, so our birthing professionals, home health agents. We've even had it be used from a school perspective in support of just what certain teachers are seeing within the classroom and transitioning
Interesting.
that into what that would look like for school-based healthcare. The
Wow.
third iteration is, I say this with a heavy sigh and a little bit of a way back when nostalgia. It's a remote patient monitoring system. So
Hmm.
when we first pushed into StatWatch, this was probably in the 2012s. The context of the time was this, hey, how do we really manage populations with chronic disease? And
Hmm.
how do we support them in remote patient monitoring in the home, caregiver access and support, and just communications, right? So we
Yeah.
were part of Commonwealth Alliance, Direct Trust, all of the messaging communication protocols and so
Hmm.
forth. My team and I thought, this is really too difficult. You just need a closed loop system that anyone can access. So we ended up partnering with a number of Taiwanese and South Korean manufacturers and
Hmm.
got the hardware that was being white labeled in the States for sometimes 7x of manufacturer price point. And
Each.
we just accessed it. So we went to market with a 2-in-1 blood glucose and blood pressure meter, right? So if you think
Okay.
about the cost of a glucose meter, cost of a blood pressure
Yeah.
meter separately, came to market with that and was sub $80. And it was for the workforce to use because it was, you could use it one to one, but it was intended to be a one to many. And the
Hmm.
strips were like 7 cents, right? And
Wow.
you could do A1C as well, which is a little more expensive, about 12 cents. But you completely changed the dynamic of being able
Mm.
to have an individual that was CLIA waived, trained on the manufacturing devices. We had our ISO 1345, getting really tactical about the
Yeah.
certifications, but
Yeah.
we had to navigate all of that, right?
Yeah.
And so, as essentially a light distributor, we're now providing access to the systems and the tools. We're training the workforce. Everything's lower cost, and that's what's intended to be. It's intended to be the lowest cost of access for the greatest amount of care for that workforce who is not our employees. It
Yeah.
is trained partners, local health departments, school systems, right? And then the kind of the coalitions and the consortiums just kept building and building and building. Now we have faith-based organizations that are running their own
Yeah.
private clinics, and that's fantastic. And we're going through the mechanisms of here's how you get, here's how you apply, here's how you get certified, here's how you bill for it. Because if you're doing the work, get the compensation, but also more
Right.
importantly, showcase the economic impact that the work is being done. Because if you cannot measure it, then you cannot showcase that there is healthcare needs here
Yeah.
and that those individuals need access. They just don't prefer to use the traditional systems because the traditional systems haven't worked for them in the past.
Do you publish that? I mean, who do you share that with? Who do you share those
It's a
outcomes
great,
with?
yeah, it's a great question. So up until last year, we never published it under TechServe. Like we would write the publications in support
Yeah.
of our clinical researchers, our principal investigators, which was always with partners, right?
Hmm.
And we never did that because we felt very strongly that as the technology undergirding, as the project management, and
Yeah.
then ultimately as the supportive evaluative on the economic impact component of it, we
Hmm.
wanted other voices. So many of our researchers were very veteran clinical researchers partnered with more junior researchers from a
Yeah.
community-based participation. And so we wanted them to not only, love their craft and support that out into the community, but we really felt like our inputs were important,
Yeah.
not the overall authorship. Well, last year was a catastrophic year. We're still right receiving federal fiscal year 25 funding opportunities that were supposed to have been already awarded and committed to the community even
Hmm.
now in June of what would be federal fiscal year
Wow.
26, right? So it's very delayed. And so it was catastrophic for us because we have a significant portfolio in federal and state. So last year in the March timeframe, we got awarded in November 2024
Hmm.
opportunities completely rescinded. So, right,
Wow.
nothing will not move forward. And our business model is because of federal, we usually have a 3-year pipeline. And it just
Yeah.
so happened that these years kind of cascade upon each other. So we knew 2025 was going to be a closing year for
Hmm.
many of our opportunities. So we hit it hard, right? At the middle of 23 all the way through 24. And we had a significant portfolio of awards going into 25. All of those were rescinded. Michael, almost 20 million was rescinded out of those contracted awards. Then in March, we were doged. So
Mm.
in 22, 23, and 24, many of the opportunities were classified as health equity.
Right.
So that was one of the key vocabulary that was considered whatever the Doge criteria was. And so then we had additionally significant number of stop work orders, which left the community really impacted. So what I mean by that is we are well known as a technical assistance
Right.
partner. And
Hmm.
so we actually will issue out local community funding on behalf of state agencies.
Oh, that's
That
interesting.
that Doge impact impacted over 170 grantees that we were managing that then no longer received the dollars to
Mm.
support and move forward. So we are very, very thankful for a number of private foundations that came in and stepped in to bridge the gap. One of those being the Robert Wood Johnson Foundation, who moved very quickly to say, we understand what's happening within the space. Here's opportunities. If you lost federal funding, apply and seek support. And so a number of our um, administrative opportunities were funded because of the academic research, evaluation, and then ultimately the necessity of it continuing in the community. But when you're,
But here's the common thing that I'm noticing now. It's
yeah,
like when you mentioned about your leadership team doing research, backing it up with data, I mean,
Yeah,
by doing that, you were able to kind of showcase the efficacy of the things that you were doing. You had the data to support it, and therefore, when these other, other alternative routes of funding opportunities came up, like you all were prepared. So
we
in
were.
kind of the timing, it's amazing how it's kind of the timing of things works. Obviously, it's like, man, this is a big setback, and then it's like, wait a second, does that teach us something? How do we learn from this? What are the risks
Absolutely.
that we carry forward? And then thinking
Absolutely.
about those as you're making your next, 3 to 5 moves ahead.
And I think that culturally, we've always been very focused on not only the intent, but the outcomes. And that's
Yeah.
important because I think you cannot be strategic on intent. You can only be strategic on the outcomes. And when we started in population health
Mm,
years and years ago, we looked at and said the goal is healthier communities. That's the goal. And if I
yeah.
look at all the different countries that have done this with prevention in mind, then the intent becomes the prevention, the outcome is healthier communities. When I saw what was happening within the federal context, of course, there was a hope that it wouldn't impact us.
Yeah.
There was also preparation. What was unprecedented was the speed and also, quite frankly, the poor communication, right?
Yeah.
Never in this 20-year career of federal funded opportunities from both my careers in telecom and in healthcare has there ever just been a okay, we're going to stop. This is not going to
Yeah.
move forward. There's been switches in direction. There has been uh, changes in how the money would be allocated or areas of funding that would have a higher focus on other, but there was never we are going to stop supporting, right?
Right.
So when we look at your earlier question of where we publish this, where is it at? We last year the aha came to be we can't depend on the traditional federal and the traditional public health communication methodology. We have to go back to good old private sector and business development and marketing foundations and really ensure that people know that we're still here, we're still doing the work, and that we
Hmm.
can help define where the funding is, where it has transitioned to, and now who has access to it. So for me, health transformation has really been a little bit of a chip on the shoulder, right? And the
Right.
reason I say that is we didn't miraculously come up with $50 billion. You got to
Right.
follow the money of where the dollars were rescinded from and
Mm,
how it's being repackaged and why
mm,
it's being positioned in rural. And
yes.
so I'll leave those as kind of open ponderings for the audience. But ultimately, looking at and saying that amount of money with a tagline of transformation requires us to shed prior precedents and
Hmm.
it requires us to redefine what does healthcare access, but ultimately economic development look like in rural.
Mm,
Because your populations will never get healthier in a community where there's no employability, no infrastructure,
right.
and no understanding of a strategic direction to help bolster all of those economic gains. So
So then,
rural, yeah.
so then talk to me about what gap are you and the team filling as it pertains to RHTP and and taking these funds and allocating them appropriately in accordance to all the things that you sort of mentioned. Like what is that gap?
So the first part is getting our rural leaders up to speed and understanding the actual vastness of the rural health transformation program dollars.
Yeah.
If you look at all of the different components, so if you look at all of the different providers, stakeholders, and who's at the table today, by and large, those are organizations that are institutions that are already part of ecosystems that have
Hmm.
defined what health access looks like. Rural health transformation needs the rural resident that
Mm.
also wears multiple hats to be at the table to say, but this is how it works in our community. And what we really need is a community center for the kids. that
Mm.
elders can also go to, that we have access to exercise and equipment, and then a convening space for all of this education and anything else that you want to account for within how do we collaborate with the community. Or they may say, actually, it's this, right? We have a
Yeah.
senior aging population that because all the kids have moved out, they're loving living in their rural township, but we don't have folks to check on them.
Right.
So
So,
what does the bridging to senior loneliness look like, right?
mm,
And it's not a problem that can be solved outside of the community. It is a problem that has to be defined by the community in collaboration with stakeholders that really understand efficiencies and also low cost economies to support access of solutions.
yeah. So here's like what I want to understand because like sounds like the money's there, the programs are there, right? The need is obviously there. What's the thing that actually prevents rural communities from getting what they deserve out of this? What's the real obstacle?
It's the governance model, right? So if you're not part of the committee, if you're not at the table, if you don't know how to apply, you're not at the table.
Mm,
It's still a
mm,
very traditional, if you look at every state has released some kind of application. And if you don't know how to do that, then you're already disadvantaged and you're already not a part of the submission. Now, if it's opened up further, now there's a number of states that have done it very well to say
mhm.
you need to ensure these categories of stakeholders are within your plan and that they have a budgeted, substantiated role to participate. Okay, great. We're getting a little bit more equitable here. But at the end of the day, the context of this is there understanding in the rural community of how this will apply to them? And is there trust that whoever is stewarding the funding has their
Hmm.
best intent and has their best interests in mind? And so when we look at the work that we're doing, what's different is simply stating here is the talking points to our rural community leaders, letting them understand this is how it can be done broadly, but now you're part of the conversation. What does it mean to directly deploy it within your
Yeah,
communities? Who would
yeah,
be interested in this, right? How do we train that person who's interested with the tools, with the skill sets, with the process, and how do they communicate back? Because if we have a plan to deploy workforce into rural, it's not going to work across all 50 states in the country, and it will be massively expensive to undertake. What we need in rural is the opportunity to be a part of this from an employability perspective, train those skill sets and tools, because then those tools within healthcare become universal in other
right.
areas and other industries. And then that collaboration also gives purpose to folks to look around and say, if the goal is rural health transformation
Hmm.
and senior loneliness is an issue, maternal prenatal education, all the way through to early childhood health and education is an issue. If opioid use disorder is still an issue, and on down the line of all of the clinical interventions, right? The question becomes, what can I do about it with these particular skill sets? And it's simple. It's showing up, having a relationship so that the conversation is one where we're collecting data across all of the intersectionalities of the individual
Hmm.
and supporting the health data so that we can solution set that with technology from a telehealth experience, a coordinated mobile, right? Mobile experience, which means that there's actually a practitioner coming to the rural environment, not every day, but when
Right.
they are there, it's maximizing their time and the care impact to the community, and on and on and on. Now, these solutions are given coordinated life in the rural environment, and we have very specific scheduling clarity and also impact clarity because of the data sets that are capturable.
So when you try to describe to someone what TechServe does, like how do you describe it today? Because to
Oh,
me, and I'll just say
yeah,
like there's this interconnectivity that you guys are doing. There's like it's this is not just an IT company. This is
no.
way, way, way more. But I'd love to hear how you describe it.
So we always give the visual of the transformation framework so that people
Okay.
can understand what that looks like. And the way that I position it is that we are an organization that helps the community see the placement and their own voice in systems transformation. Because without that, we have a lot of people creating solutions that no one will ever use because they're not
Hmm.
clearly understanding who the community is and what day-to-day problems they have today.
Hmm. Before I forget, can you just mention to people where they can find, more information about TechServe? Like just give us a little commercial and then we'll maybe do a couple fun things and we'll wrap.
Yeah, sounds great. So you can learn more about all of our program solutions on techserve.io, techserv.io. You can LinkedIn connect with me at Sunny Lou Williams. We publish twice a week. And then we can also, the next, I think, next major show that we have is the Indiana Rural Health Association's annual summit, which will be in French Lick, Indiana on June 23rd and 24th.
Excellent. All right, let's maybe do a little lightning round.
Sure. Yeah.
So maybe first thing that comes to your mind. Ready?
Yeah.
All right. The best piece of advice your grandmother ever gave you. One sentence.
Your health first, everything second.
It's funny, my parents tell me that all the time. That's
Yes.
wild. Okay. If you weren't doing this, what would you be doing?
Man, I would still be doing this in some way, shape, or form, just a different iteration of it.
Okay. The moment in your career that scared you the most.
Mm. When I was approached to acquire the division that I built and launch it, I thought it was the nicest way anyone had ever been fired. But actually, it was a conversation that was focused on doing a management buyout. And I was like, oh man, I'd always wanted to be an entrepreneur directly, but I didn't know if that was the right timing. But here we are.
Yeah. And maybe what's the most underrated thing about Indiana?
The most underrated thing about Indiana. Mm, that's a tough one. What do you think the perception
I mean, I
of
think of
Indiana
Indiana,
is
I think
today?
of like the Motor Speedway.
Yeah.
I think the Indy 500.
I think from a cultural perspective, I would say probably, this sounds like a really nerdy answer, but we've got some really good government enterprise. Like people aside, leadership aside, titles aside, we have some really, really good intra-agency development and support, which I've not seen the likes of in other states. So it's really nerdy because it's really process driven. But we have this awesome thing called the Management Performance Hub, and
Hmm.
it has MOUs with every agency for comprehensive data collection and sharing. And so the
Cool.
Management Performance Hub literally can access any data set in the state and raise it up as a research project. And so we have worked with MPH a lot, and it is awesome because in itself, it doesn't function as a technological doesn't function as a technological information exchange, but it's the legality of it, right? To be able
Yeah.
to access um, as a custodian of data. And yeah, again, super nerdy, but that's what I would say is
All
underrated about Indiana. Good question though, Michael. I have
right.
to think
All
through the
right.
pop culture reference.
Okay. And then maybe this is my last question, just because
Yeah.
you as sort of the seat that you're sitting in, and you got to look out. Maybe let's say you look out 5 years from now and looking at TechServe's work in rural health in terms of how it actually moved the needle? Like, what would have changed, within those 5 years, and what does it look like for a family that's sitting in rural Indiana kind of community that's been, waiting for something to change?
Yeah, so 5 years out, what does rural health look like with TechServe support? So in 5 years, I think that what we will have very clearly done is become the orchestration layer for all community partners, school systems, faith-based organizations, and the primary small chambers so that they understand how their just existence supports rural health. So they will be very clear on those components. And then the families themselves, because of where they work, where they play, where they live, also have an understanding of a standard of expectation
Mm,
so that if those that come into the community are not inherently supporting rural health for rural residents and they're
yeah.
supporting it for profit or they're supporting it for whatever other intent, then rural has a voice and understands how to push back.
Mm,
And in the 5 year time frame for the rural markets that we are supporting today, they will then have integrated community-based access networks, not clinically integrated access networks, but community-based access networks, where then the clinicians, providers, and practitioners go to those venues and sources and support rather than having to build out costly um, physical integrations.
it's super interesting. Sunny, thank you.
Thank you,
Genuinely, I
Michael.
think the work that you're doing really, really matters. And my belief is that people are going to understand a lot more about why after listening to this conversation. So if you're listening and if you're watching this, this is exactly the kind of work that I started, the reason why we started the show, to shed the light on people that are doing hard things in places that don't always get a spotlight. And that's what this show is built for. So if this episode somehow serves you in some way, or hit you, or just kind of tugged on something, and I've been taking I've been taking notes while we're having this conversation on my post-it note here. And you said one thing. You said you can only be strategic on the intent, not on the outcome. Like that really resonated for me. So again, if this episode resonated with you, please share it. Um, Send it to someone who needs to hear it. And if you haven't done so already, like subscribe. Like, what are you waiting for? And if there is a topic that you want us to sort of explore, or a leader you want to hear from, make sure you drop us a note. We do listen to it. So thank you for listening. Keep building with purpose, and we'll see you next time on the Advancing Healthcare Innovation Show.